Hello, I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. Well, it's another show, and I'm glad to be here, and we have the perfect person to talk about thyroid disease. But before we get to our topic, let's talk about caring and sharing. Remember, I just so appreciate all the emails and all the tweets that's coming my way. It just lets me know that you care out there, that you really care about your health, and that this show is actually connecting to you and helping you as far as taking care of yourself. So, www.medmoments.com. Don't forget the S. And also you can tweet me at MedMoments. Well, let's get to our topic. It's thyroid disease. And I have a physician that knows all about thyroid disease. He's an internist, internal medicine. And his name is Dr. Dean Rice, internal medicine. Dr. Rice, welcome to our show.
Thanks for having me.
I'm glad that you could part with some of your patients and they let you go for just a few minutes to come over and enlighten us about thyroid disease.
My pleasure.
I'm going to start with my usual question, and that is, what does the thyroid do?
Well, the thyroid is a very complicated gland located in the neck, right underneath what we call the cricoid cartilage, right in the center of the neck. And it's a gland that produces a hormone that is really responsible for the regulation of the body's functions. It produces energy, it controls some of the workings of the different organs of the bodies, and it's essential to keep the body what we call homeostasis.
Homeostasis. That means, that's a big word now. Come on.
To keep the body regular.
Stable, huh?
Keep it stable.
All right, I got you. So if the thyroid is overworking, then you're hopping all over the place. Yes. Because it gives you said metabolism, yes. Right? So
energy. Yeah.
And energy.
Yeah.
So, and if it's not working very well, then you just
right.
Exactly. Just sitting in the chair, not moving. That's about
right.
it.
Yep.
All righty. So how do you know if you have a sick thyroid, though? What happens if your thyroid is just sick?
Well, that's a good question. The thyroid is a little bit different than some of the other organs and glands in the body. You have three different disease processes that really come through the thyroid. Mm-hmm. Overactive thyroid, underactive thyroid, and then abnormal growth in the thyroid, which are associated. So when you say a sick thyroid, you have to think about which kind of dysfunction you're looking at. Mm-hmm. And it's really characterized by the prevalence or the inavailability of the hormone that the thyroid makes. So sick thyroid, if it's underactive, lack of energy, mm-hmm. overweight, irregular bowel movements, poor sleep. These are some of the classic symptoms for people who have an underactive thyroid. Sometimes thinning of the hair, loss of the lateral third of the hair on your eyelids, mm-hmm. edema in the lower legs.
Edema means swelling?
Swelling, I'm sorry, swelling in the lower mm-hmm. legs is mm-hmm. very common. Right. And overall, lack of energy, lack of adequate the processing of the major organs in the body.
Oh, all right.
So that's an underactive thyroid.
Right.
Overactive thyroid would be just the opposite. Mm-hmm. Overaction, rapid thinking, rapid talking, rapid heart beating, right. flight of thoughts, weight loss, classic. And these are the symptoms that are mostly associated with an overactive thyroid. And then another portion, another way the thyroid can be sick is overgrowth. Mm-hmm. And the thyroid is an organ that you really shouldn't be able to see. Mm-hmm. You know, if you see someone's thyroid, they're automatically sick for whatever the reason. So these, what we call a goiter or thyroid nodules, is another kind of the third dysfunction of the thyroid that we identify.
Okay. Let's step back just for a minute, because as you said, the thyroid is a very complicated gland. Yeah. Very complicated. And so I just want to get an understanding as to how and why it works for us. Mm-hmm. There's something called, can you describe this thing called the pituitary and what it does as far as the thyroid is concerned?
Yeah, so with the thyroid, it doesn't act alone. Oh. So it's under the direction, and we had a discussion earlier, under the direction or the control of the gland deep inside the brain called the pituitary gland. Mm-hmm. The pituitary gland secretes a hormone called the thyroid stimulating hormone, which tells the thyroid what to do in terms of secreting more or less of the vital hormones from the thyroid called T3 and T4. So the pituitary gland is actually in charge, in control of the function of the thyroid. And that's where you get this feedback mechanism, which makes thyroid function so fascinating and so very, very complicated that it often requires a lot of detailed investigation to figure out what some of the abnormalities are.
Okay, so let's step back just for a second now. So this pituitary gland, which is inside the middle of our brain somewhere, it's throwing off a hormone that goes to the thyroid, and that pituitary says, I want you to, rev it up, and I want you to burn some more calories or whatever you do, thyroid, so you better push out some of your hormones so that the body does what I want it to do.
That's right.
Or it'll tell it, you're putting out too many hormones down there, thyroid.
Slow
it down a little bit, because we don't want the patient, we don't want our body to be 90 pounds and then 89 pounds and then 88 pounds. You better slow it up a little bit.
Right.
So the pituitary is actually the master of all of this.
But the pituitary is overwhelmingly in control of this whole system.
Okay.
Now, which makes it a little bit more complicated, is there are conditions where the pituitary gland is not functioning well, and it makes you think that the thyroid gland is not functioning well. And that's where you get this feedback mechanism, which makes thyroid disease such a puzzle when you're trying to look in terms of what dysfunction is when in production of this thyroid hormone.
Okay. Now you talked about one thing called the goiter. That's interesting, because a lot of times we see people who have enlarged necks. Or one side may be enlarged and the other side is down. Is that what a goiter is? That what's causing that most of the time?
Goiter is an enlargement of the thyroid gland. It may or may not be actual thyroid tissue, but the gland itself is enlarged. And as you mentioned, there are two lobes of the thyroid on either side of the neck, which is connected by what's called the isthmus. It's kind of like a bridge between. So you can have enlargement in one side, enlargement in the other side, enlargement of both sides. And this we term a thyroid nodule or a thyroid goiter.
Okay.
And people with large necks, as you saw, you might go to the store to buy a shirt, and people have different neck size, 15, 18, 18 and a half. You see muscular people with large necks. That's different than to have an enlargement right in the front, right here by your, what they call the Adam's apple, a little bit below the Adam's apple. That is characteristic and really classic for a goiter and enlargement of the thyroid.
All right.
Not necessarily a large neck around, but a enlargement of the neck in front.
All right. Now, does every thyroid grow out so that you can see it? Or does sometimes they grow back and go down and you don't even see the bigness of the thyroid?
That's another one of the mysterious functions of the thyroid. You have these conditions called retrosternal thyroid. So the thyroid that we can see is the part that projects out. You can have growth in the thyroid that goes down beneath the sternum, the breastbone of your body, and you might not necessarily be able to see it. And it's nonetheless no less dangerous than the thyroid goiter, the exogenous goiter that you can actually see.
All right. Well, in thinking about that, just how we're thinking about this thyroid getting big, there is only so much room around your bones right here, and a lot of things have to pass through here. You have your breathing tube passing there, you have the swallowing tube, the esophagus passing through, you have all those nerves and vessels and arteries passing through. So what happens to all of those things if this thyroid's taking up all this room?
Yeah, that's the problem. It gets encouraged, it encroaches or pushes in on these areas. And as you know, as a pulmonologist, the thyroid can get so large, it'll push in on your windpipe. It'll push in on your esophagus or your feeding tube, and that's some of the time. That's when it's gotten to be very, very large, and those cases need to be resected.
Right. So you get short of breath. You can't swallow. Those type of things.
Yeah. With or without the overfunctioning. So you can have a large thyroid and it's not working. So you don't necessarily have to have the classic symptoms of an overactive or underactive thyroid with these enlargements, which makes it all that more difficult to diagnose.
Boy, oh boy. Now, as far as age is concerned, does this usually happen in kids, or is it more in adults that this happens to?
Well, the two different, it takes a while for a goiter to develop.
Okay.
So you don't necessarily see that usually in children. Hyperthyroidism, overactive thyroid, is usually a young woman's disease, relatively young, 20s to 40s. Hypothyroidism is usually happens later on in life, in the 30s to 50, and overwhelmingly it happens in women greater than men, and in less in African Americans as opposed to Hispanics and Caucasians.
Oh, all righty. So it's more in Caucasian and Hispanics.
Yes,
than in
black.
African Americans.
Yeah, and more in women, but it certainly does happen in men.
Oh.
You say they have numbers around 2%, 1 to 2% in hyperthyroidism, which is a little less than hypothyroidism, and maybe about 5% of people in adult years with hypothyroidism. So it's worth looking into if you see symptoms that are suggestive.
All righty. What about this? There's something called thyroiditis. Or itis. I love itis. Medicine, everything's an itis. Right. Hey, you got a problem, you got an itis over there, But thyroiditis, tell me about this.
So itis is just a term in medical jargon which means inflammation.
Okay.
So you can have an itis in any organ. You can have hepatitis, gastritis, retinitis. So it just means inflammation where inflammatory cells or cells that supposedly fight infection come to a particular organ or gland and just disrupt it.
Right.
So that happens often is the cause of underlying hypofunctioning and hyperfunctioning thyroid illnesses. Okay. So it's an inflammation, unwanted cells that come into the gland to cause a disruption.
Alrighty. Now, I know that there are times when patients will come to the office and they'll complain of weight loss, and I kind of look at that, and many things can cause weight loss, worrying and things like that. But also, it's something called, when they complain of abnormal heartbeats. Is that a part of the thyroid disease? Can thyroid disease cause that as well?
Classically, overactive thyroid often causes these rapid arrhythmias, we call them, irregular heartbeats. One of them is very, very common, atrial fibrillation. Oh, okay. Very common in hyperthyroidism or overactive thyroid. Underactive thyroid would cause just the opposite, as you might suspect, bradycardia or slow heart rate. Slow heart. So, when people come in, you have to make a decision on what kind of screening to do. And I'm glad you brought that up, because most of our tests are based on an intuitive kind of a suspicion that an individual has a particular disease. Right. So when people come in with that rapid heart rate, loss of sleep, weight loss is classic, excessive sweating, then you start to think about overactive thyroid. And that's when you start doing these tests that I guess we'll go into a little later to see whether or not the thyroid is overactive. But classically, rapid heart rate is associated with overactive thyroid.
All right. Now, the reason that one would lose weight with a hyperthyroid, is it because that you burn up your calories, like for instance your proteins and your lipids and your carbohydrates, or is the body burning it up too fast? That's why you lose the weight?
Well, that's one of the, your metabolism is increased and you use all of the nutrients that you have quicker. Oh, so you're not necessarily losing weight to benefit yourself. Right. So people tend to think if you have an overactive thyroid, that might be beneficial in some kind of way to help you maintain sveltness or maintain a slim physique, but it doesn't, because it doesn't help you to lose weight in the correct fashion, and it's associated with disease process throughout some of the other organs in the body.
So that's what metabolism means: burning up those calories.
Burning up the calories very, very quickly, and then you'll see that characteristically with excessive sweating, hyperactivity, rapid movements, inability to sleep. I said sweating, and that kind of thing.
So just the opposite for the hypothyroid.
Just the opposite. That's the one thing that makes it a little bit easy.
Right.
If you think opposites, you can think about the disease processes that are going on
one side or the other.
Yes.
I got you. Now, are there any other diseases like oh goodness, like I know, like these fancy words, and I hate to throw this out, scleroderma, or that may cause thyroid disease, or affect the thyroid, even though it's a completely different disease? Is there are a lot of diseases out there that will affect the thyroid?
Yes, and medications as well. These amiodarone, lithium, some of these medications affect the thyroid. Iodide is classic, and that's why they had added iodide to the salt, because we know everybody eats salt, and iodide is essential for the thyroid gland to convert the colloid that's in the thyroid, the liquid, from the functioning thyroid hormone. So deficiencies in iodine, some underlying other illnesses would cause dysfunction associated with thyroid disease.
So the thyroid requires the iodine to work or put out the hormone?
Put out the functioning hormone. Exactly, yeah.
Oh, all right. So without the iodine, you're
in trouble.
You're in trouble.
Yeah.
Goodness gracious. You don't even know about these things.
And iodine is only available, I mean, you have to get it through a supplement.
Right.
So
you can't make it. We don't make that.
No, it's not like vitamin D. You go out in the sun and then you get some vitamin D.
Right.
It has to be ingested. Yeah.
Interesting. All righty. Well, the thing of it is that what about with the hypothyroidism, the obesity that comes about? Is that because you just don't burn up the calories and you storing it in the fat cells and all of that?
Yep. And a lot of times you're not able to burn up any calories. People feel so fatigued. Again, lack of sleep and just overall lack of energy. It's really classic, and swelling or edema, as we had mentioned, is very classic for the condition, the deficiency of thyroid hormone or hypothyroidism.
I know I come in contact with it a lot with obstructive sleep apnea.
Yeah.
And the patients are very big, and usually they're big people, and one of the things that we test for is thyroid, that you have an underactive thyroid, and that's why you're so big, and that's why you're having problems breathing at nighttime when you're sleeping, because your neck is so big and it's cutting off your airway.
And Dr. Bay, it's so rewarding when we look at and we see a patient who has the classic symptom, as you mentioned. Obesity is an epidemic in our community, and that's the first test we do. That's one of the screening tests that we had mentioned, the TSH, or the thyroid stimulating hormone. It's such an easy test to perform, relatively inexpensive, and when you find someone whose obesity is a result of hypothyroidism, underactive thyroid, it's so easy.
Right.
You give them one pill every day, and you can actually cure this disease. This disease is one of the easiest diseases to cure and one of the easiest ones to actually diagnose when it's in its simplest form. So that's a very rewarding encounter when you see a person who's overweight, and it's overweight because of hypothyroidism. Very easy to treat.
Right. So what you do when you see a patient come to your office, and you just, as a physician, you just know this is some type of thyroid disease. What do you do first? Do you draw bloods first? Do you send them for fancy tests or scans? What do you do first?
Well, first, the physical examination it's unobtrusive, non-invasive. You do vital signs, and you get what the basic outline is of an individual. Secondly, the blood test. Now, nobody likes a needle, but it's so very easy to perform. We get such a wealth of information from a standardized blood test. And an individual, like you mentioned, this TSH, thyroid stimulating hormone, by itself will give us a wealth of knowledge about the function of the thyroid. Short of this pituitary dysfunction, which happens in less than 5% of people, but when it's primary thyroid disease, the TSH will put you right on point to exactly how you need to diagnose and treat the underlying illness. So that's a characteristic. Then from there, then you can decide how to go about with the T4, they call it, and the T3 levels, which are the active hormone that actually goes throughout the body and causes the regulation.
All right. So the T3 and T4 is what the thyroid puts out.
That's what it puts out, right.
The TSH is what the pituitary puts out.
And all of this is found in the blood. Yep.
Okay. Yep. Excellent. Now, once you know that the patient has a thyroid and the abnormalities, do you get any scans or anything like that?
You can. Well, depending upon the structure of the thyroid, we do ultrasounds, sound wave tests of the neck, and very non-invasive thyroid scans where you have this iodide uptake to see where the functioning part of the gland is to make the diagnosis. In goiters and in thyroid nodules, often we need to do a fine needle biopsy or fine needle aspiration when you have enlargement of the thyroid, which can be done in an office setting with local anesthesia, and you get a wealth of knowledge for it. So these are some of the more common tests. Then you have the free T4 and the free T3, which goes a little bit more into a little bit more detail. But we can get a wealth of information from some relatively non-invasive tests for the thyroid.
Okay, all right then. So after you get this, now does with all these changes with goiters and size and the way the hormones going up and down, does cancer ever play a part of this?
Unfortunately, yes.
What happens?
Thyroid cancer is one of the most more devastating of the cancers that are around. When you overactive or underactive thyroid disease by itself is not so often associated with cancer. Mm-hmm. Enlargements, nodules, and abnormal growths are unfortunately associated with thyroid cancers, which can be very devastating. So in anyone who has an enlargement of the thyroid, mm-hmm. the recommendation is to get a piece of tissue or a biopsy. Oh. Or if it's more fluid, then the aspiration and take out the fluid to see whether or not these malignant cells or these really bad cells are involved.
Okay. So so stepping back and talking about goiters,
yeah.
when you see a goiter like that, as far as treatment is concerned, do you give medicines to shrink it, or does the surgeon go in and try to take it out? How do we handle this thing?
That's a very good question. What the intervention is going to be when you have an enlargement of the thyroid? First, as with any abnormal growth, we have to find out what it is. Right. So all of us as healthcare providers, we really try to figure out exactly what's going on before we offer one of the common treatments. So any enlargement of the thyroid has to be addressed by taking a little tiny piece of tissue in some capacity. Okay. Usually we start out with abnormal growths with a sound wave test, mm-hmm. and then these thyroid scans to try to see exactly where the abnormality is, because as you mentioned, it can hide. Mm-hmm. And then next is to do a little aspiration or take a tiny little needle to take a piece of tissue out to make sure that it's not a malignancy or a cancer.
Okay, all right then. And then the surgeon would go in and try to take it out?
If that's one of the things to do is to remove it surgically. They have these injections that can freeze the gland and shrink it. Uh-huh. And then some thyroid hormone can be used to kind of shrink the gland in some instances.
Okay, all right then. Yeah. Because, now, hyperthyroid. I just want to get the. Yeah. I know I'm trying to.
No, I appreciate it. Thank you.
Because this is kind of confusing, and I don't want to confuse hyperthyroid. How do we treat that? If it's going too much, how do you stop it from putting it out?
Good. So hyperthyroidism, overactive thyroid,
right?
Overactivity. These are too much of the hormone which causes energy production. There are two real common medications that we give. One's called PTU, or propylthiouracil. I'm sorry about that. And then tapazole is another medication which suppresses the function of the thyroid.
All right. So it actually stops it from putting it out.
Yes, but then you have to treat the underlying symptoms, because with hyperthyroidism, you're going to have these symptoms of overactivity: rapid heart rate, excessive sweating, inability to sleep, hyperactivity. So we give this medication that's commonly used as a blood pressure medication called a beta blocker. Mm-hmm. Slow down the body response, treat the underlying problem by stopping the secretion of the thyroid hormone, and then get to the definitive treatment, which is the radioactive iodine treatment, which actually destroys the thyroid tissue.
Okay.
Now, you may think that's pretty severe.
Bad. Yeah, you just killed my thyroid. Thank you very much.
But what happens is with these treatments are for life. Mm-hmm. And the treatment for overactive thyroid disease is much more difficult than the treatment for underactive. We can actually replace the hormone that the thyroid makes with the treatment with this levothyroxine. We can give you the thyroid hormone. But to give a medication to suppress the thyroid, often it has side effects which are unwanted. Nausea, gastritis, headache, hair loss, and this kind of thing. So you don't want to treat people for too long of a period of time with these medications to suppress the thyroid. Okay. One treatment, radioactive iodine, suppresses the thyroid, and the only thing that you might have to do is take the thyroid hormone at the end for
so you take the hormone that the thyroid would be putting out anyway.
Yes.
And it keeps you normal, and then your body goes back to normal.
Right, and you won't have to go through that hyperthyroidism.
And hypothyroidism, basically you just give the patient that hormone. And they come to a normal state.
Then they have it, and they're relatively normal for a long time.
Excellent. Well, this has been a wealth of knowledge tonight. I'm telling you, you're very good. You're very good, and
thank you for having me.
appreciate you going through all of this with us. And I trust that we can get you back and we can do another topic, because this is excellent. Excellent. Thank you. Thank you. Thank you very,
Thank you. It's my
very
pleasure.
much
Thanks
for
for
coming
having
in.
me.
All righty. All righty. Well, at this point, as I flip my pages, I just want to go through our Let's Talk segment just for a second, because we don't have much time. And I want to talk about stress. And stress, how do we recognize it? Because stress can be, it can present itself differently to all of us. And sometimes there are signs that you have the teeth grinding. You may have rapid heartbeat that tells you have stress. There's forgetfulness. There's you have a negative attitude that may come about because of stress. You may be lashing out at people, or isolation, or want to be left alone, or overeating. All of these can be secondary to stress. And so you must recognize that you are having stress, number one. And number two, then you must do something about it. Take a walk, calm down, try to have a hobby. It always helps. Do something that you like. Relax, comfortable in your favorite chair, just kind of kick back. You want to talk about it. Sometimes talking it out really, really helps as far as, stress is concerned. And laughter is the greatest thing in the world. All righty. We've come to the end of our show. And in closing, I want to say caring and sharing. Remember, www.medmoments.com, and at MedMoments. You can tweet me as well. Email me out there. Don't forget about me, guys. Never institute any change in your medical therapy until you consult your physician. I trust that each and every one of you have continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace to you all. All righty. Thank you very much, Dr. Rice. Thank you for coming in. Excellent show.
You led me through it.
That's a tough topic, too.